Hey everybody, it's Dr. Wood, and today we're going to be talking about epidemiology and biostats with lecture 13, where we're going to be looking at surveillance of epidemiologic concerns and how we actually investigate outbreaks. And here are some objectives we'll cover as we go through this. And so we've talked about surveillance briefly before. We know this is the process where you're collecting, analyzing, interpreting that data. The point being is to try to characterize, incidents of a lot of different things like death, disease, etc., whatever the case may be as things are coming up. It could be surveillance of carbon monoxide exposures in Florida during hurricanes. It could be anything. CDC is going to be really helpful for a lot of that, especially if it's going to be in sort of like an interstate sort of issue. That's where the federal government really likes to come in, or it could be requested. So if in a particular state you see something kind of strange going on, you could always contact the CDC to come and help investigate there. And they can then kind of decide whether or not this is truly like an interstate kind of concern, or if they can handle it locally, things like that. And so, as we mentioned, CDC helps out with more like federal sort of stuff. So again, if it's interstate, the federal government kind of has first intervention there, especially if it's like, a outbreak that occurred in one state and then people are then traveling, say via airport or something to other states. That could be a really big concern. Typically, if it's within a very enclosed area, then state governments tend to have kind of first shot at investigating those issues there. And then it could expand out if it becomes more of an interstate sort of issue. So how they develop the systems of surveillance will be defined by several different things. And it depends on the type of disease, the type of condition that it's going to be. For example, you could be looking at specific types of infectious disease. So, for instance, if you're worried about Ebola spreading in the U.S., that could be something you're looking at. Could be if you're looking at incidents of Guillain-Barré secondary to like a vaccine. Could be really anything that you're looking at. Obviously, I care a lot about poisons, and so we look at things like new and upcoming designer drugs. So like when bath salts were coming about, we did a lot of epidemiologic surveillance on the incidence of bath salts. We did a lot of surveillance when we had Deepwater Horizon, which was that big oil spill that happened several years ago. A lot of different things could be used with surveillance mechanisms. And so it's really important that you set up clear objectives. And so, for instance, maybe you want to have a surveillance program that looks at chickenpox to determine if the varicella vaccine is effective, right? It's a very clear delineation. You're not looking at any other types of vaccines and incidents of disease. You're just looking at varicella and chickenpox, right? By having those clear objectives, you prevent yourself from getting like kind of too outside of your scope, and you prevent yourself from really being ineffective by trying to look at too many things. And so when we're creating these surveillance systems, it's really important that you determine the criteria for how you actually define a case, right? And so you don't always have to have everything defined out at the very beginning. Sometimes these case definitions will evolve as time goes on, but it's really important that for at least starting out, you have really good standardized reporting procedures, right? Or at least forms where people are able to collect data at least somewhat consistently in order to make sure you're comparing apples to apples when you're looking at different cases there. How you define those cases is typically going to be defined on, say, certain clinical findings, say agranulocytosis, or say it's going to be something like, presence of certain UA findings, right? Laboratory results, any of these things can be included with that. Or it could be actual data concerning things like the time and the place or the characteristics of people who are affected. So it could be, all right, anyone who ate at this restaurant who developed nausea, vomiting, diarrhea within, say, 12 hours of eating at the restaurant, right? That could be the definition for a case. Also, you would like to know the intensity of the planned surveillance. So if it's an active versus passive sort of thing, again, active typically requires more effort, more money, things like that, because you're actually having people call and collect data actively versus just having things kind of passively reported to you. And you also want to know the duration of surveillance. How long do you plan on doing these sort of things? Then you'd want to know what sort of analyses you're looking for. So are you looking at incidence, prevalence, if you're looking at people who have the disease and then who die from it, so you get your case fatality ratios. All those sort of things should be stated in advance, so that way you're not trying to, at least you know what kind of data you're going to be collecting there, and you're not having to go backwards and trying to make up for something you might be missing, right? So it's important to have an idea of how you're going to analyze the data before you get started. And so with all that information in mind, then you develop some objectives and methods that are going to be put into place to help aid the investigators in collecting, then reporting, and then using that data there. And what oftentimes we'll do early on is actually do like a pilot test program to see and sort of kick the tires, so to speak, and try to see how it's going to work for you before you try to put it into a more of a full-blown, say, nationwide sort of system there. However, as you're going through, it doesn't mean that that's once you institute the surveillance program that's done. You have to go back through and if something's not working, go back and reevaluate it and see if you need to adapt it any further. And so if you wanted more information, certainly you can check out the CDC, and they'll give you lots of information regarding all kinds of different surveillance mechanisms. So as I mentioned, most of the surveillance we do on a routine basis is passive because it's pretty cheap and easy to do for the most part. However, you have to understand that you tend to have underreporting for a lot of these conditions here. But this is good for things that maybe don't really require a whole lot of active surveillance that we're not maybe super interested in right at that particular time, or maybe it's not like a high priority for the given time period. And so this is relying on people like physicians or laboratories or hospitals to report these things. And even though we consider some things to be mandatory reporting, doesn't mean that it's always going to happen there, right? We have no real way of sort of enforcing that sort of thing, as it turns out. Active surveillance, as I mentioned, typically requires things like weekly phone calls. Sometimes it requires individuals to actually go out to sites and collect data there. As I mentioned, it's labor intensive and costly, so we don't do it unless it's something that's like really high priority or something that's really considered to be severe potentially. And so you're going to see that the percentages of reportable diseases that actually get reported can vary pretty considerably. So, for instance, if you were to look at a passive reporting system, it can vary between, say, 1/3 to 2/3 of cases. Maybe with active reporting, you maybe get a little higher than that. Just depends on the disease and how the actual surveillance is being performed. Sometimes you may notice that like a change in care may uncover a problem that was not known previously. So for instance, we had this hospital in Connecticut that was reporting these cases of pharyngeal gonorrhea in young kids, and they thought it was a localized outbreak. It was something they weren't expecting to happen there. And so they ended up having a group come out from the public health school at Yale, and they actually started looking into it, and they were noticing that the outbreak, so to speak, started occurring after they were examining all throat cultures in kids that were presenting for beta hemolytic strep. Also, they were looking for gonococci. And so because of that, they just started to examine more patients for that. They did better surveillance there, and they started to notice all these cases. There's probably a lot of kids that were having this pharyngeal gonorrhea beforehand that just were undiscovered, right? So by changing clinical practice, by changing treatment modalities and diagnostic modalities, you can start to uncover quite a bit of things that might have been previously invisible. For a lot of conditions, you're going to see that the reporting doesn't tend to be super rapid or nationwide, especially if it's not sort of a big national priority at the time, and that these systems tend to be developed on a problem-by-problem basis. So if a new, so if like, for instance, Zika virus becomes a big national concern or a state concern, especially here in Florida at the time, there was a new surveillance system put in place for that, right? And because without these systems having good support and funding from governments, whether state or federal, it's difficult to develop and to keep in place, which is why a lot of these things tend to go to more passive reporting. They tend to, have kind of it kind of takes up less mind share for a lot of practitioners as it kind of moves to the back of their mind as some new sort of condition or disease sort of comes in vogue, so to speak. And again, you have to see that a lot of these systems tend to begin as these demonstration projects, sort of field projects to kind of see how they work at first, and then they tend to expand out from there. So what are we going to do when we are trying to establish one of these surveillance systems? First off, you have to get what the baseline is, right? So you want to know what the sort of usual patterns and rates of disease are going to be based off of other regular reporting or surveillance systems that might already be in place, right? And so epidemiologists, they like to look at these patterns of diseases by both time and geographic locations of cases. So for instance, now we're entering the winter months, we're going to be seeing a lot more cases of flu, which is certainly time-based. And you also want to look at the characteristics of people who are involved, right? So you want to see who is more susceptible to disease than other individuals potentially. And then once you get your baseline, then you do continued surveillance, and it allows you to look for deviations, right? Allows you to look for changes to see if there is a problem going on or if there is sort of an epidemic brewing, for instance. And so they can look to see Is it epidemic? Is it unusual incidence of disease for that time and that place and those type of individuals? Or could there be other factors involved here? Could it just be alterations in reporting that could be responsible for those observed changes, right? Have definitions changes, have diagnostic modalities change? What has happened to cause these numbers to go up? And is it actually a true increase or not? And so usually the implication of these really long-term sorts of studies tend to be more significant than, say, if you're just looking at a one-time outbreak or epidemic, because you will see these sort of national changes and national trends. And so here's an example of a graph that was taken from the CDC looking at salmonellosis, and they were looking at the number of reported cases seen over time. And this is important because if you're looking at a long period of time, you notice these trends, there's probably something bigger going on than if it was just a one-time sort of outbreak. And so looking at the trend, you have to wonder, is it because that we are detecting the disease more readily? Is it being reported better? Or is it both, right? And so when you have a real or suspected outbreak, it can increase the index of suspicion. And so people are more likely to test for it. People are more likely to think about it. And actually you can find that will increase both the diagnosis and the reporting because more people are just thinking about it. And so here you can see reported cases kind of going across several years, and you're noticing that the reporting is consistently going up. So is it actually true that they were having more cases being diagnosed? Well, probably, right? They have more cases being reported, sure. But is it because we're having the same number of people, just fewer reports as later on, say the 1980s, or is the actual number of cases really going up, right? Certainly you can see a one-time outbreak, but then things tend to go back down to the normal soon times afterwards. And also think about this: if you hear in the news that there's a big outbreak, and you particularly, that happens close to where you're working, you may be more likely to test patients for this, and thus reporting and diagnosis is going to go up just naturally because of that. And then things tend to go back down to the mean. You tend to see things will balance back out. And so what the epidemiologists, by looking at those trends, they were noticing that going from 1955 to 85, that increase was certainly real. It was due to increasing number of outbreaks, and they saw that trend extended for a long period of time. And then even they could base it off of the different locations. So for instance, in New England and the East Coast, there's a sharp increase of outbreaks. Was noticed beginning about 1977, right? And so it could be related to the types of foods that are eaten there. It could be related to environmental factors. It could be a lot of things there. And so when you see these kind of long-term increases in the disease in one region of the U.S., that can usually be of a greater concern than just a very localized outbreak, say to a certain town or a certain restaurant. And again, it will kind of suggest that maybe there's a bigger, more widespread problem than just simply, a few extra outbreaks occurring. And so to give you another example of some of these time trends, I'll show you a graph here reporting the incidence of mortality from diphtheria in the U.S. And so basically what the graph is going to do, it will illustrate the advantage of using sort of a logarithmic scale for some of this reporting here, because you'll see that when you're looking at the incidence and the mortality, they'll show sort of a parallel decline. If you were to look at it on a normal sort of scale there, it might not be quite as apparent. But looking at this, you'll see that the decline in rates were proportional to one another, so that when you saw a percentage of cases that were resulting in death, or that case fatality ratio that we talked about a few lectures ago, you're going to see it remains relatively constant. So it's going to be about 10%. And so it goes to show you that even though the cases were going down, we will not see necessarily that our treatment's gotten any better, but because there are fewer cases, there's fewer deaths to go along with that, even though it still tends to be about 10%, right? So what we're seeing is that prevention is really getting better, but not the treatment. And so here's an example showing you that. So looking at this, we can see the case fatality ratio over time. Again, this is going back to the 20s all the way through, say, the 70s. You see here that our treatment has not gotten any better. The patients who still get disease are still likely to die, or 10% likely to die there, right? Versus when you're looking at the mortality and the incidence, you can see here they're going down pretty much parallel to one another, right? So this is showing us that the cases are going down, even though that our treatment's not any better. So again, just a nice way to kind of visualize the data, to kind of show us like, what are we doing, what's happening here, what could be the results of that, right? What could be the reasons why we're seeing these changes. So looking at seasonal variation, right? So we see this all the time with a lot of infectious diseases. We're going to see that we can look at usual cases or rates of disease, and we can look at the expected seasonal variation and try to incorporate that into the calculations, right? So it would look like we're having flu epidemics every single year, but that's really just part of the seasonal variation. You think about especially different types of infectious diseases where certain periods are going to have the highest incidence, and usually depends on the route of spread. So, for instance, infectious diseases that spread via the respiratory route, so like influenza, they tend to have a much higher incidence in the winter and the early spring months in the northern hemisphere. A lot of the reason for that is a lot of people huddle together, tend to see that people are inside more. They can spread things around to each other a little bit more easily, right? There are other reasons, but that's one particular one. Or, for instance, when diphtheria, it tends to have a spike in incidence, and that's mainly due in the early autumn sort of period there. It's also because a lot of kids are going back to school, right? So they're able to kind of spread it around to one another in those cases there. If you're looking at diseases that are spread by insects or arthropods, right? So if you imagine like mosquitoes spreading certain disease around, that tends to happen more in the summer or the early autumn period, right? Because when they tend to be a little bit more active. Or like things like Lyme disease or things that are going to be tick acquired. Maybe you'll see that late spring or the summertime when patients are outdoors and they're in the woods and doing things like that. So also they're wearing less protective clothing because it's hot outside. All these things can have a seasonal effect on the incidence of disease. And again, some of that stuff can be really normal. You may see a big uptick in the incidence, but that could be just part of the seasonal variation. Sometimes we'll see that certain health problems can vary by the day of the week. So, for instance, we'll find that things like recreational drownings happen a lot more on the weekends, probably because kids are more at home and they're playing and by the pools and things like that than they would be during the weekdays. Here you can see a graph where you look at the number of drownings. You notice Saturday and Sunday tend to be the highest incidence here. They can happen on other parts of the week, but again, much more likely when everyone's at home and kids are playing and things like that, right? And so when we're looking at these epidemics, we're looking at disease outbreaks, we're looking at the occurrence. Again, we want to look to see, are there any unusual frequencies happening here that could be indicating a true epidemic? Now, when you say epidemic, that tends to create a lot of panic in the population, especially when you start to have these pop up on like news organizations and things like that. So sometimes the term outbreak is used for more localized sort of epidemics. That makes it a little bit more tolerable to some people there. But what we can do to try to determine if the level of disease is unusual is that first we have to know what the usual rates are going to be, and then we also need to have reliable surveillance that kind of shows us that are the new rates that we're seeing here, the new incidences, is this in excess of what we would consider to be normal, right? So you have to know those two features there. Otherwise, you don't really know if the numbers you're seeing are normal, abnormal, or something else. And so for instance, when they're trying to determine when and where influenza and pneumonia outbreaks occur, CDC typically are looking at things like seasonally adjusted percentages of influenza and pneumonia. They'll look at the deaths and the number here, and they'll develop what they call an epidemic threshold, right? And so they'll then compare that with the reported percentage to say, okay, well, if we have these number of cases here, we're going to consider this an epidemic. If it's below this, then it'll just say that's part of the normal seasonal sort of variation there, right? And so, again, we include pneumonias because oftentimes influenza-induced pneumonias typically get signed out as just random pneumonias. They don't really mention the influenza in the first place. That's why they end up usually including pneumonia in that definition there. And so what you can see, looking at this graph here, you'll have that the actual solid line here is a seasonal baseline, kind of what you would normally expect based off reporting trends. You'll have the epidemic threshold, which if we start to get those numbers above that, you're going to see that would be considered to be an epidemic. If it's below that, then it's not. And then the black line is the actual proportional number of deaths. And so you can see here that, for 1994, not really a big problem. Getting into 95, looks like there was an outbreak or an epidemic. 96, there's an epidemic. So you're starting to see, hey, wow, maybe these seasonal trends we thought that were sort of normal, seasonal variations, maybe there's something else to this. Maybe we need to readjust these numbers here because we're seeing a lot of epidemics developing every one of these years. And so typically the introduction of new major interventions that try to change patterns in a population, so say if we were to introduce a new vaccine or something, those are also things we want to try to surveil to see, are we noticing the intended changes that we're looking for? Are we seeing the numbers actually go down after we introduce the vaccine? Now, if we were to see a failure of the vaccine to produce any sort of satisfactory changes in terms of the actual incidence, it could be seen by one of the following things, right? So maybe we're seeing a lack in change of disease rates, so they're remaining pretty constant even though more people are being vaccinated. If we're seeing an increase in disease rates after an initial decrease, right? So maybe the efficacy of the vaccine is not very good, or we are seeing an increase in the disease rates in a recently vaccinated group, right? So perhaps if they had, for instance, bad lots of polio vaccine manufactured back in the 1950s, they noticed that even the people that had been vaccinated starting to see an increase in the rates of disease in those individuals, right? All of that could be detected by some of these surveillance programs. And so one really good example of how the importance of surveillance was noted was when they were looking at the surveillance of measles rates in the U.S. And so they were noticing this detection, or they detected the failure of initial vaccines really providing long-lasting protection. They noticed that even though individuals were protected the first few years of life, that they were starting to lose that as time went on and they become adolescents. And so by researching into that problem, by looking at those trends, that's how they came up with newer recommendations for immunization. So basically they were saying that, hey, the first dose should probably be given, say, 12 to 15 months old. That way they prevent issues of failure rates due to maternal immunity to the baby. They were saying that a second dose should be given around 4 to 6 years of age, and then a third dose is usually recommended before they enter college. By noticing these trends, that's how they were able to come up with a new vaccination schedule. It wasn't like they did a clinical trial where they compared people who got 2 shots versus 1 shot. They just did it from the data here, and they noticed that by implementing these changes that they're able to see, okay, wow, we're getting a lot better rates here. We're seeing much fewer cases of measles being reported year to year. And so those patterns of disease for a current time and the recent past help us to determine priorities for disease control efforts, right? So they help kind of set the priority for both state and federal agencies to determine how we need to be funding things and how things become a priority. And so, for instance, the disease would be of much more concern if the rates are increasing rapidly. So, for instance, in the late 80s to early 90s, because we were seeing AIDS rates going up pretty dramatically, that's where it became a much bigger priority. Or if, say, for instance, severity of disease is a pretty critical feature, a lot of people are dying from it, had a high case fatality ratio, that would also be a good reason to start to do some good surveillance there. And so, again, because AIDS was killing a lot of people and it was having a rapid increase in rates in that time frame, became a very big priority due to its potential for epidemic spread. And so by looking at those patterns of occurrence and over time, it allows us to change understanding patterns of a disease. And so, for instance, we're looking at cases of syphilis in New York City during the 1980s. It was really interesting because they started to notice this changing patterns of acquired and congenital syphilis, right? So not only the people who are acquiring it, but also maybe infants who are picking it up. And so they noticed this big increase in the number of cases, both primary and secondary syphilis in women in particular, beginning in 1987. And they noticed that this was happening around the same time as the epidemic of crack cocaine began, right? It was an epidemic because crack cocaine was relatively new on the scene at the time, and so those numbers are going up pretty dramatically there. They also noticed there's a increase in congenital syphilis that was associated with the women's use of cocaine. And at this point, they noticed that, hey, once they did more investigation, that a lot of it had to do with the fact that these women were oftentimes trading sex for drugs, right, for that crack cocaine. And they also, were having lifestyles where they're not having a lot of good prenatal care. And so, again, sometimes these patterns of occurrence can be more ominous than just simply more cases of syphilis. It could be related to some other underlying issues that we can uncover once we start to do those epidemiologic investigations. For instance, here you can see this black line is going to be primary and secondary syphilis in women, and then they notice congenital syphilis rates here, these gray bars. And again, right around 1987, you start to notice a huge spike up here, and a lot of that was related back to the introduction of crack cocaine at that time frame. And as we've mentioned, common definition for an epidemic is really just the unusual occurrence of disease. Even though people really think that it has to involve a large number of people or has to be spreading across the nation, even one case of it could really be considered an epidemic. So imagine if you had one case of smallpox, that would be pretty significant there. That would be considered an epidemic. If we had any cases of poliomyelitis in the Western Hemisphere, that would be a big deal because it just doesn't happen really ever. Or measles cases in the U.S. So, for instance, here if you're looking at 2010, it only had 63 cases versus here in 2019, we're already up to 1,250 cases. So, I mean, just looking at this, you can see that, especially in 2014, this is certainly outside of the normal. 2018 starting to spike up again, but then 2019, here we go, like a lot of cases there. So again, even though it's only 1,250 cases out of 300 million some odd people in the U.S., that's still considered an epidemic. So when you have a disease that is occurring pretty regularly and at a sort of constant level over time, we consider it to be endemic. So certain things are endemic to a population. So for instance, things like malaria is going to be endemic to certain parts of Africa. Things like influenza could be endemic here in the US for sure. And so when you're looking at these acute outbreaks, you have to kind of measure the disease frequency. We're calling that the attack rate, especially when we're looking at exposure over a short period of time here. And so we can look to see how even endemic things, how they normally occur, we can kind of look at this attack rate of current times and see how that's going to be comparing to it to see what's going on there. And again, rather than this being considered a true rate, as we talked about them before, really this attack rate is going to be the proportion of people that might have been exposed to an illness and they actually become ill themselves, right? So essentially how we'd calculate this out would be the attack rate is equal to the number of new cases of a disease divided by the number of people who are exposed to that particular outbreak times 100. Now we can get it, and remove the fraction and just have an actual number there. And so when you're looking at these forces, kind of for and against the occurrence of disease, typically they're in equilibrium, right? That's why we see sort of normal trends in these numbers here, where the numbers don't change a whole lot. When an epidemic is occurring, that usually means equilibrium has been disrupted, right? So for instance, if we are looking at influenza rates and we notice that maybe the vaccine that they selected for in terms of the strains it protected against wasn't very good that year, that equilibrium has now been disrupted. And so the goal when you're doing these investigations is to try to discover and correct the recent changes. That way the balance can then be restored back to normal and hopefully control that epidemic. Because again, we know that some diseases we're never going to get rid of, but we want to at least keep it sort of at the status quo, so to speak. And so people who are alert to possible epidemics not only would be concerned to, say, give the correct treatment to individuals, but also ask, well, why did this patient become sick with the disease at this time and place when maybe they normally would not have, right? So what has changed to cause them to get sick at this time versus simply just saying, okay, let me just go and treat you and be done with it. So first step here when you're going to be investigating an epidemic is to establish a diagnosis, right? So this is where we have to come up with a case definition here in order to determine, okay, what are we even looking for? And so it may seem like a pretty obvious step, but a lot of people can oftentimes start investigating an outbreak without really even taking the first step here. A lot of times cases are solved by just making a correct diagnosis, right? By showing that oftentimes the disease occurrence really wasn't that unusual in the first place. So for instance, when there was a health department in North Carolina, they got a lot of panic calls from people who are concerned about the occurrence of smallpox. And we mentioned even one case of smallpox would be a really concerning sort of thing there. And so a physician working in a local health department, he was assigned to investigate it, quickly discovered that it was actually just typical cases of chickenpox, right? The reason why the issue came up was because the child's mother did not speak English very well, and someone just heard pox, and they just started panicking, right? And so just by making the right diagnosis, the outbreak was sort of stopped, right? Oftentimes these easy misunderstandings can then propagate and can become a bigger problem, so to speak, than it really is. Or again, here there really was no problem. So then you want to establish your case definition here. It should be a list of very specific criteria to decide whether or not a person has the disease of concern, right? This may not be the same as a clinical diagnosis. It could just be say, okay, we're going to have a certain set of signs and symptoms, certain laboratory values, things like that come up to be our case definition, right? And these are designed to cast a pretty wide net to catch as many people as you can, and then eventually you can rule people out based off of once you get a little bit better case definition design there. But you want to use consistent criteria to try to proceed even before you get a definitive diagnosis in a lot of those cases there. So for an example, if the CDC has a case definition for eosinophilic myalgia syndrome, and their definition included a total eosinophil count greater than 1,000 cells per microliter, generalized myalgia at some point during the course of illness, and then exclusion of other neoplastic or infectious conditions, right? So by using this case definition, anyone that presented with these three things would be considered in that case definition, right? They may still have something else going on, but they at least fit this definition for now, and then you can do further investigations to see do they really have the disease. And so no case definition is going to be perfect because there's always going to be some false positives. So you tend to find that the sensitivity tends to be pretty good for a lot of these early case definitions, but their specificity might be not great, right? So you have some false positives, but that's okay. And so we're going to find that individuals without the disease get wrongly included. That's those false positives we mentioned. And there also could be some false negatives there where you're having some patients who you consider to be disease-free, but they really weren't, right? So we know they're not perfect, but they're at least a good starting point there, and allows us to start to kind of carry forward the investigation. We can adapt as time goes on. So the epidemic should really be characterized by time, place, and person, using that criteria for the case definition, right? So you don't really want to start data collection if you don't even know what kind of data you want to collect, right? And that case definition will help you determine, okay, well, do I need a CBC, like that eosinophilia myalgia syndrome we talked about a second ago? Do I need a UA? What do I need to collect data in order to determine, do my patients even fit the cases or not? Time is going to be important here as well, because time will help you determine like when exposures might have happened, and so typically you're going to be graphing these out where time's on the x-axis, where new cases are going to be on the y, and that can really give you an idea of like how are these things spreading, where is it starting at. I'll give you some different examples here how we can investigate those. And so we create these epidemic time curves such that the units of time are going to be a lot smaller than what we would consider to be the probable incubation time for the disease itself, right? And the y-axis, as I mentioned, is going to be that number of cases that become symptomatic during each time interval. And so the point here is you can kind of get a very good view of how the disease is evolving based off the new incident cases that are coming up. And so it provides us several clues here, these epidemic time curves, and they can tell us a few things, such as what type of exposure do we have? Was it a single source? Or maybe was the spread from person to person? What was the probable route of spread? Was it maybe fecal oral or skin to skin, where there may be exchange of blood or body fluids, things like that? And then when were the people exposed? What was the incubation period? And then in addition to just the normal primary cases who were initially exposed to the common source, where are there secondary cases? So people who then spread it person to person. And I'll give you some examples of each one of these as we go forward. So when you're looking at common source exposures, this means that basically people came into contact with a source, the same source, and it could be something like contaminated water, could be food over a short period of time. And so with these, you typically see the epidemic curve will have a very sudden onset, a peak, and then a pretty rapid decline. So once they're not exposed to the food or the contaminated water anymore, then it goes away. If the outbreak is due to more person-to-person spread, then we consider that to be a prolonged, irregular pattern. We can consider that to be a propagated outbreak. So you could have one common source exposure, but then they kind of spread it to their friends, and they spread it to their friends. It's called propagated. I'll show you a picture here. They'll show you an outbreak of gastrointestinal disease caused by a common source exposure due to Shigella at this Fort Bliss in Texas. And basically, it was spaghetti that was contaminated by a food handler. And you see the time scale is going to actually be in 12-hour periods, and the time period is going to be dependent on the type of outbreak you're looking at. And you'll notice a pretty rapid increase and then rapid decrease of the outbreak. So you can see here that every time period is being broken up by 12-hour time breaks, right? You're going to be seeing, and again, the numbers here are actual days, and the number of cases here. So you see here that relatively few people were meeting the actual case definition, maybe just one person. Then you notice this big spike right here, and then it goes back down, and then very rapid decrease, right? So one common exposure probably caused the majority of this, and they weren't necessarily spreading it to one another afterwards, okay? So this next one is going to show you what a propagated outbreak would look like. This is going to be a case of dysentery that was occurred by Shigella that was transmitted from person to person. There's an actual school where this is being spread around to one another. And so basically it was through contamination of persons and clothing. And again, when you're at a school environment, there's very close quarters, very easy to spread things from one another. And here you're going to see the time scale showed in 5-day periods because of a longer incubation time there. And you'll sort of notice the ongoing or dragged out sort of appearance, as opposed to that sort of single source exposure we saw just a second ago. And so here you can see in terms of staff members versus residents who are being exposed here, you can see here's one particular index case. And then again, going over 5-day periods, see the index case returns back to the school. And then what you notice here is this long kind of dragged out. And again, more and more people are kind of spreading it to one another. See it peak up and then start to go back down as cases are resolving. But again, it's much more dragged out over the course of many, many days, over the course of, 2 months practically, versus just having one big spike and it go back down pretty significantly, right? So it's more of a propagated sort of attack. So, and then under certain conditions, things like respiratory disease spread from person to person may produce a curve that almost looks like a common source exposure. So here would be an example of a case of measles that was spread in an elementary school. And so basically by having this widespread exposure occurring in a school assembly, basically it was being spread around the air in the assembly, and it was thought of as a common source exposure. Now here what you're going to find is that the initial case in the situation was called the index case. That's going to be the person who actually introduced the organism into the population. Kind of consider that be your patient zero, so to speak. And so you'll find these sequential individual cases can be seen even 12 days or so during that prior 2 months. So, and again, the first time you caught this case of measles here, should have been warning the school and public health officials, hey, we probably make sure that everyone's immunized appropriately. And if it had been done, the outbreak probably would have been avoided, right? But that did not occur, and so you're going to see these cases pop up here. So this index case back in December, see a few other kind of sporadic cases through January, and then now they have this school assembly, right? So then you're seeing that they're spreading it to everyone. You see this big outbreak that occurs here. It looks like a common source sort of exposure, and then they had a vaccination clinic, and then you notice the cases go down pretty dramatically. A few sporadic cases, again, some people didn't get vaccinated, but this is how these cases tend to occur. So it looks like a single source actually caused a long time back in December by this one index case. Sometimes you'll see that an epidemic has more than one peak. So for instance, if you have multiple common source exposures, or maybe because of secondary cases where they're spreading it to someone else. And so those curves are really helpful for helping us to determine that. So we'll look at a case or curve of shigellosis that occurred in students who attended a camp in the eastern U.S. And basically what had happened was the campers who drank contaminated water were then infected with Shigella. And then as they returned home, they infected people back at home. So you end up seeing kind of two peaks that occur here. So you notice here again, we're looking at a 12-hour period. You can see that the campers are going to be the white bars, the sort of darker shade are going to be campers that were not on the trip. And then you have the bus driver. And so you can see here that initially you're going to have the campers who are exposed have a big peak in incidence, and then it's going to come back down. But then you'll notice here a little bit later on, some of the campers that did not go on that particular trip who were never exposed to that contaminated water tend to peak up there, because then they're then spreading it to those individuals. So it's sort of a secondary sort of exposure to that propagation. So there's situations where you may have two different common source exposures, right? That could be happening at the same time, same place, but at different incubation periods, right? So imagine someone gets exposed to contaminated shellfish in a restaurant. You may have two different diseases occurring here concurrently. Maybe shigellosis occurs in 24 to 72 hours, but then there's also outbreak of hepatitis A that occurs 2 to 4 weeks later, right? Two different diseases coming about from the same common source exposure. So determining the place can be really important here. Looking at how disease clusters on a map can give you really important clues about how the disease is occurring, where the sources of exposures might be. Sometimes a geographic picture itself may not be entirely useful unless you have other data to sort of correlate along with it. But sometimes a spot map itself can be really important for showing you sort of where affected people may live, work, or go to school, right? And that can show you maybe where the exposure was actually happening. We've mentioned this back a few lectures ago, talking about cholera occurring back in London, how they were actually able to center it on one particular pump that was infected. And basically once they capped off that pump, then they were able to remove that threat, and they saw that the epidemic was already starting to wane there, right? Again, looking at this spot map here where the cases of cholera were occurring, you notice here very sporadic cases as you get further out, but then as you get closer and closer in, there's one particular water pump here on Broad Street that had the most exposure surrounding it, and they were able to identify that, yeah, this is probably where the disease is coming from. So using the spot maps can be limited because, at that point we only know the numerator. We only know the number of cases we have, but not necessarily the total number of people that could have been exposed there. And so what we normally would do is prefer to show these incidence rates by location. So we may look at it, for instance, show it by hospital ward. So we can look to see, in a hospital infection outbreak in a particular area of the hospital. We can do it by, say, work area, classroom, or say a certain section of a city, right? You can look for more sort of community sort of outbreaks. And so when epidemiologists want to determine the location of a disease and sort of how it's spreading, they can then compare those trends in those particular areas and then compare that to other areas or regions to see how they sort of compare there. So for instance, here we're going to show you a figure that's looking at salmonella enteritis that were occurring in the U.S. between 76 to 89, and they'll show you different geographic locations to kind of compare and contrast between the others to see, well, are there really any changes that were occurring here? And we'll see that certainly that there's pretty high rates in New England versus some of the other areas. And so you can see this dark line here is going to be New England. You see pretty high rates as compared to elsewhere. But then what do you notice sort of towards 1984? Well, then you start to see the Mid-Atlantic start to peak up here. As time goes on, you could have maybe seen things like, South Atlantic started to pick up, etc. But you can look for these trends over time and certainly see that, yeah, there's something abnormal happening here versus some of the other areas. Sometimes we'll be looking at reports of clusters of, say, cancer or other types of disease in, say, a particular small area or like a neighborhood. And again, just from the theory of random sampling, there are certain things we would expect to see just by chance alone. And this is the challenge with epidemiology, is that you're going to try to determine what's chance clusters from actual real clusters. And again, just by saying, hey, 3 people develop leukemia in this one school, that could just occur due to random chance and not be a real common problem. And so, as I mentioned, the types of cancer in a cluster may be really helpful to distinguish whether or not it is an environmental problem. So, for instance, if it is a cluster that varies a lot in type, there are different types of cancer, so maybe one person has lung cancer, another person has prostate cancer, then it's probably not due to a single hazardous exposure, right? Typically what you'd end up finding is that more people would have the same type of cancer. So for instance, if you had a bunch of people that developed thyroid cancer all at the same time, then that may lead to a more intensive investigation because they could all be linked to the same sort of toxic exposure. Knowing the type of people who are being affected here is also very useful to help clarifying the problem. Looking at different things like their age, ethnicity, religion, all these things can all be important because it could be influencing the type of exposures they have, the type of places they go, the type of people they interact with, and can really help to define sort of, the scope of the problem potentially. So I'll show you a few figures here, for instance, that shows the value of analyzing, say, personal characteristics of people that are exposed or that contribute to an outbreak. The first one's going to look at age distribution of measles cases in children in the Navajo Nation, and then a second one shows age distribution of measles among residents of Cuyahoga County in Ohio. So again, looking at patients of a Native American group, and then patients in, say, of a more typical, suburban sort of area. And so if you're looking at kids in the Navajo Nation, you notice here that the rates of measles was quite high in kids that are less than 1, right? Comparing that to cases that were happening in Cuyahoga County, Ohio. What do you notice? Well, the cases in kids less than 1 are very low versus up going through, ages 10 to 13 or so. You're starting to notice these biggest spikes here. So what was the difference at the time between these two groups, right? So you have to go into, well, what was it about the people? What type of practices did they have? How are they vaccinating? What type of exposures were they having? What was the difference between these two? And so the fact that the measles was occurring so early was probably consistent with the fact that a lot of those individuals were not immunizing kids that were young, that were preschool age. The fact that kids in Cuyahoga County did not have a lot of cases very young probably showed that they were vaccinated, right? They were immunized to prevent that outbreak from occurring very early on, right? However, you notice that they were having a lot of disease rates later on. So the kids in the Navajo Nation who were exposed early developed pretty long-lasting immunity. They didn't develop it later on in the teenage years, versus the kids who were immunized in Ohio tend to find that even though they were protected early on, the sufficiency of that immunization was not great, and so later on they tended to develop it later, right? And that was before they changed how they were actually dosing the vaccine. So other things we can look at, so when we're developing our hypotheses about the source, type, and route of spread, we want to know that the source of the infection is the person, typically the index case, or the vehicle of it. So whether it's food, water, whatever the case may be, we want to know kind of what was bringing it together in those cases there. And looking at the pattern of the spread is going to be how that infection can be spread from, say, source to the individuals that are going to be infected, right? So we need to know, is it going to be something that's spread person to person? Is it something that's via a certain common source exposure, like a contaminated water, thing like that? helps give us a better idea of how these things are actually spreading. So as I mentioned, when you get those propagated patterns, that's typically when things are being spread directly from person to person over that extended period of time. So even though they may have a common source exposure, once they start spreading it from person to person, either through respiratory means or through fecal oral routes, things like that, that's where you get more of that propagated pattern. Sometimes, though, you may find it's even a mixed pattern where people will get that disease from a common source and then spread it amongst their family members and other individuals, or the secondary cases there. So a lot of it just depends on the type of disease you're looking at, but that's why you do the investigations to find out, well, what kind of pattern is it? And so a lot of infections will have different types of spread. They may have more than one. So for instance, when you're looking at Shigella, that can be spread through both contaminated water as a common source or person to person. So you have more of a mixed sort of picture here. HIV can spread through different routes, such as intravenous drug users sharing needles, or it could be happening from person to person through sexual contact, right? So more of a propagated spread. And so by looking at this mode of transmission, we can see that, it can be respiratory, it can be skin to skin, it can be exchanging of bodily fluids, etc. And looking at the rates here, looking at the changes in time, all this can help us with the information we need to define the problem. So laboratory studies can also be really important for helping us to test our hypotheses about epidemics, and it can include more than one or more of the following. So for instance, looking at cultures from possible vehicles, you can look at from patients, you can look at stool examinations, for instance, you can look at serum tests for antibodies. They can kind of tell you whether someone has had an acute infection, or more convalescent serum samples that maybe show you that something has happened a long time ago. And then looking for other type of tests that look for toxins or particular drugs, right? Say, for instance, you're looking for cases of syphilis related to crack cocaine, and you tested those individuals and they were positive for cocaine. That could show you an example there of seeing how the exposures were occurring. And so a common, efficient way of testing hypotheses is typically we like to do a case control studies. And so, for example, we can do it with, say, a foodborne outbreak of disease. What we can do is determine cases who meet our definition and compare them to control patients who did not meet the definition. So we look at things like risk factors, like what type of food was eaten. Was it just people who ate the shellfish that developed severe gastrointestinal disease? Was it more common in people who are the cases than they were in the controls, right? You look at the presence of those risk factors, get those odds ratios, and they can help you to define sort of what risk factors were present in the cases that were not present in the controls. And so you'll question both groups regarding the specific foods they did or did not eat before the outbreak, and that will help you to isolate it down to maybe one particular food or one particular drink, as the case may be. And then the food item showing the greatest difference in consumption between the cases to the controls was probably the most likely risk factor there. And so we can use case control methods for other types of, say, non-infectious disease. So for instance, this is kind of an interesting case where they had 8 young women with adenocarcinoma of the vagina that were treated at one hospital between 66 and 69. And it's a really rare type of cancer. And so the reason that, or the fact they had 8 cases of it in the short period of time, was considered an outbreak. And so what they actually ended up doing is a case control study where they compared 32 controls, so basically 4 matched controls or similar people to every case they had. And what they noticed was that the only real difference between the cases and the controls was that 7 of the 8 cancer patients had been exposed to diethylstilbestrol in utero, or basically their moms were exposed to it. And so DES is actually a synthetic estrogen and was typically given at the time during the first trimester of pregnancy to try to prevent miscarriage and premature labor. Now, we don't use this drug anymore, mainly because of what we actually found here. So it's crazy because you're finding that these adult women, they're young, but they're still adults. They're developing these types of cancer, and they were able to link it back to something the mom was exposed to through a case control study, which is pretty wild if you think about it. And so they found that none of the 32 controls of the offspring of mothers who had received any DES. So it seemed very likely that this was the common link here. This is the common thing that linked all these 7 cases together. And so the probability of finding that association by itself, just due to chance, was extremely small. They would say pretty convincingly that, this is probably the reason why this occurred. So when an outbreak occurs, there's usually going to be an outcry that something has to be done, right? We have to fix this problem immediately. And so it's necessary frequently to take control measures before you even know what the source of the outbreak is, before you know the route of spread is known for sure. And so when you do this, when you initiate a control measure, it should be initiated in a way so as to not really interfere with the investigation of the outbreak. There are different types of interventions we can use to control an outbreak. Sanitation is going to be one of the most frequent one, and this involves modifying the environment. So it could be removing a pathogenic agent from the source of infection. So say changing the water supply, maybe switching over to bottled water, changing the food. You may be removing the source of a human infection. Say you quarantine off a person from exposing other individuals, or you prevent the contact with the source, maybe by removing susceptible individuals from the environment, right? So maybe taking, say certain kids who are at risk out of school, for instance, right? Different things like that can be used to modify the environment. You can also do prophylaxis, right? Putting some sort of barrier to infection with susceptible hosts, right? So we can do things like immunizations that may be recommended for an entire population. And we usually start that during infancy, right? We can also do things like short-term protection for people who plan to travel to other countries. So if we know someone's going to be going to areas that are endemic for malaria, we give them anti-malarial drugs potentially, right? And so looking at the diagnosis and treatment of these people who are infected so that infected individuals do not spread that to others, right? So making sure we're treating them so that way they're not going to be infectious to others. And then also things like controlling of disease vectors, things like controlling mosquitoes, and things like that can all be really important. So although an outbreak may require one or more interventions, you may find that the outbreak just fades away on its own, right? If enough people have been infected, then that pool of susceptible individuals goes down on its own. And so one important thing to look at in terms of the control effort is to look at the written and the oral communication of findings to the appropriate authorities, health professionals, and the public, right? So there's usually some dissemination of information that will allow other agencies to help control the disease. It allows for healthcare providers to be more aware and kind of keep it on the forefront of their mind. It also allows for us to start to do things like, spread information regarding prevention, treatment, etc. And so once you have these control measures in place, it's important to do follow-up surveillance. And so you always have to follow these things up to make sure the outbreak is truly under control, to make sure that you don't have a new epidemic that's popping up, to make sure that the control measures you put in place have been effective. And so typically what happens is you'll start off with active surveillance after the fact, and then eventually trade back into more passive surveillance as it becomes less and less of a priority. So that's how we go through and do surveillance and investigate outbreaks. If you have any questions, certainly let me know, and I'll see you guys next time. Thanks a lot. Bye.